Dr. Shapiro is an elected member of the American Society of Clinical Investigation and also a past president of the Society of General Internal Medicine. His new book, The Present Illness, American Healthcare and Its Afflictions, has just been published by Johns Hopkins University Press. It has appeared on the Amazon Healthcare bestseller list, I am told, and Dr. Shapiro relates, this book will not be his last, so we look forward to inviting him back in the future. Thank you for joining us.
Thank you. Well, I'm really delighted to be here at the Regenstrief Institute and at the University of Indiana. I have many friends and many other people who I've long admired from a distance, and I've had a great time meeting with quite a number of you while I've been here. So when my wife was offered a job as a department chair at Mount Sinai Medical School in New York, I gave up my position as division chief at UCLA and had an opportunity to think about what I might do next. She reminded me that I'd been threatening to write a book about American healthcare, and I decided to do that. I'd entered academic medicine, like many in general internal medicine, with the belief that we would do research that was going to change medicine, if not the world. And we fell far short of our aspiration. With this book, I hope to do penance, and I hope to engender some serious discussion about how we can get back on the right track and begin to fix things. In writing it, I had no difficulty enumerating problems in many domains, but it became apparent that all of these problems weren't just incredibly bad luck. They must somehow be linked. And to understand why that might be, I had to explore evidence and theory across multiple domains. I also felt that it was important to relate what I'd learned to my own experience and in clinical medicine, in education and research, and to show how the problems are linked. I learned a lot, and it took much longer than I expected. The process was humbling, but I encourage you to consider stepping away from the hurly-burly of academic life at some point, and if you can, take time to think about how to put down on paper what you've learned in a broader perspective and try to nudge or encourage society to move in those directions. We need that. So this talk has elements that are intended for audiences that are less sophisticated than this group about health services and health policy research. But I'd like you to see how I'm presenting some of these ideas to others. And it's my hope that if pre-med students, medical students, other physicians in training, practitioners across the specialties and leaders of organizations in healthcare were to consider some of these kinds of ideas, it might shake them out of their career-driven complacency and complicity with the current set of priorities. I have no conflicts of interest to declare, although I will acknowledge that I used to sometimes wear a button that proclaimed that criticism is an act of love. It is a great time to be in medicine. It's a time of scientific breakthroughs. It's an age of exploding knowledge of mechanisms of disease, an epoch of extraordinary profits for healthcare businesses, a season of life-saving medical interventions. It's the spring of personalized medicine. Indeed, some feel that with the current advances, we're all going to approach immortality. But is that the whole story? It's also a time of clinical neglect. It's an age of blissful ignorance towards chasms in health and of personal bankruptcies due to medical debts, of choosing whether to pay for health care or for other basic needs. Those personalized medicines are very expensive, can cost tens of thousands of dollars per month. It's the winter of avoidable deaths of those whose problems lack priority, and immortality is far from a consideration for those facing premature death. So why is it so hard to fix healthcare in America? If we're to make more headway, I believe that we need to think in a different way than we have up till now and act accordingly. What's rotten in the state of healthcare? You're all well aware of these problems. Disparities in access and health, high costs, and poor outcomes are among the most prominent features of dysfunction. And I won't dwell long on the well-characterized manifestations of dreadfulness in our system, but lack of insurance for many, even after passage of the ACA, and underinsurance for even more. Our health expenditures far exceed those in other countries as a percentage of GDP. Back before 1970, the US wasn't such a spendthrift. Expenses were comparable to those in Canada and other countries relative to GDP. That changed with respect to Canada when Canada adopted its national health plan. Over that period, the US has steadily fallen behind other countries with advanced economies in life expectancy. Indeed, over the last half century, life expectancy has improved in many countries, most, but less so in the US than in other countries with advanced economies. Before the pandemic, lagging about 3 to 5 years behind many of these countries, even more than that now. So why has it been so hard to pull the right levers and create policies to solve these problems? I believe the problems are multifaceted and go well beyond the tried and true targets of most policy proposals and research. And the ways in which the various groups of actors conceptualize health and healthcare, pursue their interests and perceived needs, and interact based on these conceptualizations, create impediments to a system that is rational, just, and efficient. Let's look at the group of actors that I argue all stand in the way of equitable, efficient, and effective care. These include practicing physicians and their organizations, medical schools and universities, corporate providers of care, hospitals, health systems, medical groups, dialysis, nursing home, and pharmacy companies, other corporations in healthcare, pharma, the biologics, those manufacturing machines, devices, and information systems, health insurance companies, of course, and investors, but also scientists and scientific organizations, the government, employers, and patients, their families, employee groups, and many community organizations. I believe that 3 phenomena shape the circumstances and the experience of healthcare in contemporary society. They are the treatment of healthcare and health itself as commodities by all actors within and without the system, the consciousness of these groups of actors, their attitudes, values, perceived needs, expectations, interests, and capacities, which condition conceptualization of health and healthcare and much of their behavior related to it, and the nature of communication and relationships among these groups of actors, which reinforce existing arrangements and impede change. Real-life cases make these issues more than mere abstractions. Luis was a 23-year-old from Central America with a mild learning disability who lived with his parents. He had congenital immune deficiency and required immunoglobulin infusion since birth. Early on, he developed Hep C infection from an infusion. When he was 7, his parents moved to the US and he came to my teaching hospital for his care. We took care of him for 15 years. Meanwhile, his Hep C progressed to end-stage liver disease. The liver transplant service declined to list him for transplant, saying that he had no insight about his illness and his parents both worked, so he did not take medicines consistently. They believed if he were transplanted, he would not reliably take medicines needed to prevent rejection. My residents and I sat down with the family to discuss his situation in Spanish. It turned out Luis had never missed a single dose of medicine. Because of his illness and disability, his loving parents had chosen to work different shifts, so he was never alone if he needed a medicine or became ill. He also did understand his illness and the importance of taking his medicines. At his bedside, we couldn't help but note the family dynamics. His parents totally devoted to him, but without the transplant, he was going to die. We shared this information with the liver team. They pointed out he was undocumented and that while coverage had been arranged for his routine care, he did not have insurance to pay for the procedure. I spoke to the transplant surgeon, noting that we'd cared for him all these years. He said he would waive his fee, but we'd have to get the hospital to cooperate as well. The associate director of the hospital, which ran at that point annual surpluses of around $200 million, told me that it was a considerable expense to do a transplant And even if they waived all the charges, the patient would be unable to pay for his medications in the long run. I implored him to pursue it and see if Medicaid or other sources might cover these costs. He said Medicaid refused, and the hospital's decision was final. Our only hope was to get him to another hospital that might try harder, and there was a hepatology fellow as frustrated as us who contacted other programs in the region. One agreed to take him, and we learned that they were able to get the procedure authorized, and he was placed on the transplant waiting list. So Luis's story illustrates many salient issues. Notwithstanding an apparently acceptable outcome, the system had failed. Even after we showed that he would be able to take his medicines consistently, that his parents were very supportive, that his time in the country was a mitigating circumstance, he would have been sent home to die. In American healthcare, some lives are cheap. In cases like Luis's, the problem isn't only tunnel vision of some doctors who fail to collect vital information, but also the priorities of the health systems, including America's so-called best hospitals. A far from acceptable quality of communication with patients and their families also can stand in the way of patients getting the care that they need. So my main point today is that fixing healthcare is so very difficult because of the interplay of consciousness, the commodified world of healthcare, and the toxic relationships and problematic communication that pervade it. Resolution of these challenges requires acknowledging this interplay and addressing it. Now, a warning, I will present some potential approaches to the problems I identify, but few, if any, will come to pass unless we broadly address these phenomena that undermine progress. Let's consider the various groups of actors in turn. Major health systems, academic, non-academic, for-profit, and presumably non-for-profit. Behavioral distinctions between these types of organizations is far from clear, and they contribute to the problems in a number of ways. Early in my career, my department had a retreat, and the keynote speaker was a senior executive of Henry Ford Hospital in Detroit. He regaled us with an account of their business strategy and how they increased sales. Then he paused and said, "Would you refer to as hospital admissions and outpatient visits?" That was clarifying. Far too often, the business strategy of these systems is to maximize market share of covered lives, maximize reimbursement for services, minimize risk, meaning poor people with Medicaid or no insurance, especially when needing lots of care, contract with healthy populations, promote lucrative product lines, prioritize expensive procedures, make deals with industry, strive for 9-figure surpluses, and reward executives with 7- to 8-figure salaries, of which 30% nationally are performance-based. Can we alter the incentives for these corporations and their executives? Not easily, but there are a few things we might consider doing. Don't pay health system CEOs salaries that are up to 50 times what some of their doctors earn. End bonus payments to executives based on financial performance, and require full participation of all their clinicians in Medicaid for health systems to maintain nonprofit status. Among other corporations in healthcare, the producers of goods are also interested in sales. These corporations are in the business of inducing demand. Pharma and the biologics advertise shamelessly to patients and providers, convincing the former that their products will extend life and improve its quality without regard to how much or at what cost. They raise prices when they can, often recruiting academic economists to justify exorbitant so-called price points, extend patents with minor modifications, so-called evergreening, restrict competition, and struggle mightily to prevent negotiation of prices. Equipment manufacturers pressure medical groups to buy their products by letting it be known that competing clinical sites have done so. They fight hard against taxes on their products. The market for information systems is an oligopoly in which pricing is prohibitive for small practices. They increase the cost of care and the work of the provider for benefits that may or may not be forthcoming. The health insurance industry sees single payer as an existential threat and fiercely resists expansion of public coverage while prodding allies in government to privatize the more lucrative components of existing public programs. They also add to problems with the current system because to maximize revenue, they minimize risk, and too often do this by denying coverage for procedures or offering products with large co-pays and deductibles, and they add greatly to administrative costs. Their co-pays, deductibles, and denials are an enormous burden, saddling many with insurmountable medical debt. Other elements like nursing homes are motivated to maintain their revenue streams. As for investors, hedge funds have moved aggressively into the health sector, seeking to inflate apparent value through maximizing billing revenue and cutting corners, then selling at large profits. Their level of public spiritedness might be compared to that of Gordon Gekko in the film Wall Street. Thinking about all these groups, policy changes aimed at fixing corporate behavior are unlikely to have much impact without much broader changes. There are many wonderful idealistic physicians, but practicing clinicians and their professional societies have economic interests that are quite obvious. The payment system reimburses procedures far better than evaluation and management. Inevitably, procedural specialty societies resist redistribution of income to cognitive fields by occupying up to 70% of the seats in the RVU Update Committee, which advises Medicare on fees. They produce guidelines that justify their activity, and they minimize risk by optimizing insurance type and run the till as long as they can. UCLA residents used to joke that the cardiologists in their hospital only had 2 indications for invasive cardiac procedures, lub and dub. Those are the 2 heart sounds. So everybody with a heartbeat met the requirements. The ways in which the health system pays for services shape the ways in which physicians practice. As you're all aware, the income differences between procedural and cognitive fields are stark. In fact, they've grown since the resource-based RVS was implemented in Medicare. At the same time, doctors were not selected into medical schools primarily to be empathic, caring, and altruistic. Many physicians handle uncertainty poorly, are not well trained to limit care, and are more comfortable with narrow tasks like procedures than building relationships with patients. Accordingly, the choices many make of specialties are driven by efficiency of income generation. Communicating effectively with patients is not well rewarded and often is actively avoided. David was a medical student doing his 3rd-year clerkship in internal medicine, very smart and highly motivated. I was the attending physician on the ward. His knowledge of disease and treatment were at a very high level. He interacted extremely well with members of the team and the nursing staff. He was terrific with patients, sensitive, open, caring, committed. He obviously loved what he was doing. I shared my impressions with David. I told him I believe he'd be an outstanding resident in internal medicine. He told me he loved the rotation and could imagine himself in internal medicine, but that he'd been advised by other students not to do that. Quote, "Your test scores and grades are too good. It would be a waste," unquote. They were saying that his level of medical school performance would qualify him for a higher paying specialty. Nonetheless, he promised to think about what I'd said. As you can see here, the proportion of residency positions filled by USMGs bears a linear relationship to specialty incomes. Several months after our conversation, David came by my office and asked if I'd write a letter of rec for him for residency, and I did, but was disappointed to learn that he had chosen to go into anesthesiology. It's likely he'll be a terrific anesthesiologist, but his awareness of what it meant financially was, in a sense, a corrupting influence on his career decision. Why doesn't society value so-called cognitive specialties more than it does? Such work is no less complex and demanding and no less life-altering for patients. I think part of the explanation is that we do a poor job of getting that message out. I can relate illustrative stories in this regard from my experience. A patient who needed constant coaching and repeated discussions of evidence and emotional support to stick with treatment for Hodgkin disease. A person who was dying and in pain but needed to hear from a physician whom he trusted that it would be okay to end active treatment. A patient with severe hypertension and serious mental illness that made it hard to adhere to treatment and show up for appointments, who needed a doc who would stick with her and keep her alive. A patient who was dispirited by multiple morbidities and needed her doctor to manage her complex regimen, but also to keep her spirits up. All of us who practice in cognitive fields have many stories like this that we can and should share about the value of what we do. Can we change clinicians' priorities and competencies? Here are some ideas. Pay doctors for their time, not for piecework. Specialty pay should only differ modestly to account for differences in time and training. Incentivize clinicians to seek therapy to help them better understand and relate to patients, their needs and their values. All physicians should have periodic training in communication, negotiation, ethics, morals, and social responsibilities. And the latter topics ought to be covered in required courses for hospital administrators as well. Mandate that procedural specialists and hospital administrators meet regularly to discuss strategies and set targets to reduce use of low-value care rather than the opposite. How about educational institutions? Universities and medical schools have considerable interest in the status quo and are part of the problem. Medical school admissions are limited almost entirely to those with great GPAs and test scores and pay little attention to values and ability to empathize and communicate effectively. Not surprisingly, the great majority admitted have studied the biological and physical sciences and related disciplines and overwhelmingly represent those from privileged backgrounds and underrepresent Blacks and Hispanics. Medical schools do a poor job of identifying students with commitments to societal betterment that are more than window dressing on applications. The undergraduate curriculum is science-based and biologically reductionist. Humanities and social sciences are at best an afterthought. The white coat ceremonies on entry are an exercise in triumphalism for people who have accomplished nothing yet but have been told that they've arrived. Students go through a well-described negative socialization and loss of idealism that medical schools don't show enough interest in arresting. Once selected, students don't learn nearly enough about how to relate to patients and next to nothing about ethical obligations and social responsibilities. Some who arrive purportedly to follow, intending to follow in the footsteps of Mother Teresa, rapidly decide to pursue the highest paying specialties. Student debt does not preclude eventually living in comfort, but provides a rationalization for these kinds of decisions. In postgraduate training and clinical training, there are many wonderful clinical teachers, but it's the exception, not the rule, when faculty model the kind of judicious, evidence-based application of technologies and commitment to diverse populations that might make America less exceptional. Again, there's little exposure to humanities and social sciences, few opportunities to address doctors' personal challenges that stand in the way of effective relationships with patients, and little effort to assure that they're able to communicate effectively with patients. Some institutions try to provide positive outpatient experiences, but in many programs, they're famously awful. Residents who are pressed for time are assigned patients whom the faculty often don't want to see themselves. These features of the training and the greater attention given to developing procedural skills rather than effective communication promote choices of procedural careers. There are lots of potential strategies for changing attitudes, values, and priorities and career choices in medical school graduates. Here are a few ideas. Replace pre-medical science requirements with humanities, ethics, and social sciences. Lewis Thomas proposed that over 40 years ago. Develop mechanisms to identify and select applicants driven by altruism, not prestige and income, and who demonstrate capacity for empathy, psychological openness, and sound moral and ethical foundations, sustained commitment to societal well-being. Let members of underserved communities nominate medical school matriculants. Ethics, morality, social responsibility, and communication skills should comprise up to half of the first 2 years of the medical school curriculum and be integrated into clinical training, which should consistently encourage psychological openness and give more weight to social context of illness and less to biological reductionism. Clinically, medical schools are no less interested than the private sector in generating revenue by favoring good insurance, maximizing market share, and so on, and marketing their lucrative product lines. The health of the public is not a priority beyond the occasional lecture on the social aspects of medicine. Practices are often segregated by insurance type, and as with their teaching hospitals, the business plans reflect the priority of revenue generation: grow market share, minimize risk, run the till. This is the so-called hidden curriculum in medical education. Students learn these lessons well and grow up to emulate the practice patterns and values of their faculty. When I entered medical school, my uncle commented that I'd have the choice between figuring out how to make a lot of money and how best to serve humanity, and that on the basis of my choice, people could then judge my worth as a human being. That was very provocative, but the provocation was a gift, and I still ask myself if I'm doing enough. Many medical students and residents would benefit from such provocation, as would some of their faculty. Almost all medical school research funding comes from the feds and industry. Medical schools are very interested in patents and royalties. The priority of maximizing such funding and grants and contracts affects hiring decisions. Social scientists and humanists don't get patents and don't bring in large grants very often, so relatively few are hired, which limits intellectual diversity in many schools. Promotion is often driven by funding and publication count and empirical studies, and not a whole lot of consideration is given to the challenges of social and community-based research in hiring and promotion in many institutions. In thinking about science, it's worth considering Robert Merton's characterization of its ethos. He identified 4 components: universalism, it's subject to verification, anyone can contribute; communalism, findings are products of collaboration and are assigned to the community. The ethos is incompatible with technology defined as private property; disinterestedness, which is objectivity about the outcome; and organized skepticism, which is suspension of judgment and detached scrutiny of beliefs. Does this ethos characterize medical research today? Not entirely. Basic researchers tend to be excited about discovery, not really educated about societal context or social responsibility of scientists. Since the Bayh-Dole Act passed in 1980, I think Bay was an Indiana senator, patents can be lucrative for scientists and their institutions, and along with large grants and contracts for some, they are a consummation devoutly to be wished. And these priorities are very apparent to students in the sciences and affects their attitudes towards what's important. Clinical research, when funded by industry, payments can be generous, but priorities often are those of industry, and intellectual freedom may be quite limited. As for the late translational policy research that a lot of us do, most tend to genuflect before the status quo in terms of healthcare organization. Few studies look at substantial transformation. Most focus on small changes and limited populations. To paraphrase California politician Jess Unruh's famous axiom about politics, money is the mother's milk of academic research. The NIH is the source. So in thinking about where they dispense their milk, look at their mission statement: to seek fundamental knowledge about the nature and behavior of living systems and the application of that knowledge to enhance health, lengthen life, and reduce illness and disability. And its programs are designed to improve health of the nation by conducting and supporting research in the causes, diagnosis, prevention, and cure of human diseases. They do not treat all aspects of this mission statement equally. Scientific organizations and funders like NIH keep promising imminent miracles as a justification for increasing the budget for the research that they do. Their relentless pursuit of molecular explanations affects the practice of medicine, encouraging attitudes towards disease as being largely asocial. It influences public perceptions as well. They produce a narrow vision of what science could be and promulgate a flavor of the decade to keep money flowing their way and not towards other kinds of research that might have a larger impact on the health of the population. And of course, they fiercely defend their shares of the research budget. When I wrote my first R01 grant proposal, an HIV outcome study, I got an excellent score, but I was not funded. I spoke to the project officer at NIAID where I submitted it. He told me he thought it was a really good proposal, but not to resubmit there because the director did not consider such research to be his responsibility. He redirected me towards what is now AHRQ. Here's a breakdown of the NIH's nearly $50 billion budget, along with those of AHRQ and PCORI. As you can see, there are some large institutes that support health services and behavioral research at times, but it may fluctuate wildly from year to year, or when there's a change in leadership at an institute, it may decrease dramatically. Other institutes never support such research, essentially. A few consistently do, but most of the ones that do have budgets the equivalent of less than 1% of the overall budget of the NIH. Can medical science be more responsive to societal needs? The scientific community doesn't appear to be in any hurry to change its priorities, but here are a few things that might make a difference. Training and social responsibility in science should be a core and substantial feature of scientific education. Revenue from inventions funded by federal grants should accrue largely to the government, not to scientists and their institutions or corporations. Research on bringing effective care to populations should be NIH's highest priority, and half the members of the advisory council of each NIH institute should be nominated by members of diverse communities affected by the disorders in which they're interested. Government, which can be part of the solution, is often part of the problem. The US government tends to avoid policies that necessitate raising taxes. They're susceptible to corporate and interest group pressures. They're reluctant to limit care and offend any constituency. They ineffectively regulate the FDA, Medicare fees, and insurance products. They overpay for procedures relative to cognitive services. Their policies promote specialization, and they tend to prefer looking to moonshots, typically asocial biological approaches, rather than society-wide programs that might do more good. Are patients and their families the innocent victims in all this? I think not, although many suffer consequences of the other groups of actors' behavior. Just as the scientist, the clinician, the pharmaceutical company, and the health system see healthcare as a commodity, so too do many patients. They want their share of the goods. Many would, of course, prefer not to pay for it. When it costs 18% of GDP, who'd want to work 7.5 hours a week to pay for their medical care? But they want the blood test, the scan, the bed in the ICU for the family member. And beyond that, many treat life itself as a commodity, wanting more days, weeks, months of life, whatever the cost or consequences for others. There's no more thought of the common good among much of the public than among those working in the health sector. Why is that? In part, it reflects a world in which almost everything is commodified, in which autonomy is unmediated by concern about dire consequences for the overall well-being of the public, in which some people feel entitled to get whatever they want, and in which many people, often are not well connected to others, are replete with loneliness, insecurity, dissatisfaction with life in general, or beaten down by the world, and come to the healthcare setting looking for solace, comfort, companionship, a heart that's open to them in the way that the larger world is not. Unlike those who demand care out of entitlement, who often get what they want, these individuals encounter professionals who are not equipped to give them what they need. And their beliefs and attitudes may be shaped by a government promising moonshots, a medical profession that doesn't know how to set limits, a scientific establishment that holds out the promise of imminent conquest of diseases that afflict society, lack of clarity from government about what limits are reasonable, and dogma from some religious leaders about when life begins and how it should end. Robert Bellah and his colleagues' wonderful book, Habits of the Heart, provides useful insights. In part, they say that American individualism has become an autonomy dissociated from meaningful societal integration, damaged by destruction of subtle ties that bind people together, leaving them frightened and alone. Many abandon any notion of finding meaning in relation to society as a whole, and in particular in the idea of the common good. When education becomes an instrument for individual careerism, it cannot provide personal meaning or civic culture. There is a fractured imbalance between individualism and communitarianism. Underlying the actions of all the actors are the values and consciousness of society as a whole outside of the health sector, including acquisition, exploitation, inequity, lack of communal concerns, mistrust, atomization, lack of fulfillment. Greed is good, poverty is weakness, decline of religion as a source of support, failure of public discourse to address these issues, and in healthcare it manifests both in relation to the economic and political behavior of the actors and in terms of their inner lives. Healthcare is highly commodified, and health and life as well. Everyone wants a piece of the $3 trillion pie. Some actors induce demand and raise prices. Others seek greater market share of people with good insurance and market lucrative products to them. Some run the till and never say no to a patient or family member. Some are interested in inventions that might enrich them and seek royalties and consultation fees, start companies. Patients are complicit. They want their share of the commodities of care, health, and life. All of these groups are pushing for the system to do more. On the other hand, insurers, the government, employers, each in their own ways and for their own reasons, want to limit care and its costs and coverage in ways that are not necessarily consistent with optimal health. Only public sector providers and other clinics for the poor try to do the right thing, albeit with inadequate resources. When care is commodified, there's a disincentive to spend time talking to patients, relating to them, getting to know them, caring for them. There's an incentive to do more, sales of pacemakers, imaging studies, pathology services, hospitalizations, surgeries for marginal indications, excessive consultation leading to additional testing, higher copays, costlier insurance, exacerbating disparities, needless consumption of some resources like ICU days, limiting others' access to these resources. There's little time and few resources to address social determinants of disease and the context in which patients experience disease and treatment. And there's diversion of resources from other societal needs like social services, education, and infrastructure that might do more for health. Can healthcare be optimized in a commodified marketplace? Ethicist Edmund Pellegrino wrote that putting clinicians at financial risk can lead to loss of professionalism. Market relationships rarely extend beyond the act of selling the commodity, which has grave consequences in medicine, and only government will put public good above private interests. Economist Kenneth Arrow contended that healthcare cannot meet the conditions of a perfectly functioning market due to uncertainty about the quality of products that patients purchase. Injury to some caused by unconstrained markets may not be offset by benefit to others. Pellegrino and Daniel Callahan conclude that commodified healthcare is inherently unjust. And among advanced economies, the relatively freewheeling US healthcare system is perhaps the least efficient, while producing poorer outcomes than so many others. But commodification isn't the only problem with healthcare, and addressing it, although necessary, won't be sufficient. The consciousness of the actors is no less potent a force. Clinicians who enjoy doing things that are concrete and short-term and who have trouble relating to patients and saying no are not going to limit care and change the system's priorities. Medical schools can't help but be generative and train more and more specialists, even at a time when the National Academies insist that there are grave shortages of primary care, nor do they know how to break with their propensity for selecting students based on narrowly defined vision of merit rather than on the basis of capacity to care. Corporate leaders lack the training or interest or incentives to pursue societal obligations. Patients run down by life in our society who are isolated, who need human contact, who have pain that's literal and figurative, or who don't trust medical authorities from whom they're socioculturally distant, and who are confused by misinformation about what medical science has to offer, look to medicine for the healing touch. Scientists are off figuring things out and mostly oblivious to societal problems. And politicians talk about their moonshots and dramatic programs and are certainly not interested in offending any constituencies. The discourse that emerges is very disappointing. Doctors selling procedures to patients and provider systems advertising miracles, professional societies guarding their interests, medical educators promulgating values of the status quo, scientists in the NIH making extravagant promises, corporate speech inducing demand and blocking progress, politicians talking about their moonshots, media sensationalizing reports of scientific advances while failing to put them in perspective, and rarely reporting on systemic problems in care, health policy researchers rarely threatening the status quo, and any public intellectuals trying to balance the discourse are drowned out. Jürgen Habermas's theory of communicative action is relevant. We can only consider it briefly today. But progress in society depends on common understanding of ends and the nature of interaction across four groups: those who control capital and produce commodities, those who develop and implement policies, individuals and groups seeking interpersonal influence, and the values and beliefs of members of society. In general, capitalists communicate very well with policymakers. Other elements are shut out. In healthcare, the power rests with capital, abetted by government and professional organizations. Absent common understanding, adversarial situations such as malpractice suits, insurance denials, collection agencies, misdirected priorities in research, clinical programs, and medical education, and poor communication and clinical encounters all ensue. This occurs because of a set of relationships in which all of the players tend to reinforce the worst instincts of all the other groups. Far too often, all of them influence others in ways that tend to exacerbate problems rather than solve them, and all of these groups lose sight of the common good. So what is to be done? Policy change can't be sustained when almost every group of actors wants it to fail. A number of philosophers, George Lukács, Karl Korsch, Antonio Gramsci, Herbert Marcuse, Jürgen Habermas, have all written about the prospects for substantial societal change and say that just pulling a policy lever without addressing consciousness, values, attitudes, expectation, needs, and so on, will lead to failure in the end. In healthcare, there are so many material goods at stake and so many non-material factors that mesh with current arrangements that all the groups of actors would be more inclined to bear those ills we have than fly to others that we know not of. Is meaningful change possible? So many actors are caught up in commodification of care, limited by their values, attitudes, and perceived needs, and promulgating or receiving problematic communication. We've touched on a lot of these problems in this talk, not all, but we need to take on a large number of these challenges in this maelstrom of dimensions of commodification, consciousness, and communication in health and healthcare. As academics, what can we do? Well, educators, clinicians, and researchers should think strategically about how many of these problems we can take on in our own institutions and in our own behavior when there are so many barriers to progress. But we can't ignore them all, and we really shouldn't ignore any of them. Vincenzo Camuccini's painting of the death of Julius Caesar represents artistically our current conundrum in healthcare. It wouldn't have been enough to neutralize Cassius or Brutus. Analogous to the fervent opposition of actors in healthcare to the prospect of reform, everyone who greeted Caesar in Pompey's theater on the Ides of March wanted him dead. Changing policy won't be enough. Transformation needs to occur contemporaneously at the levels of policy consciousness and communication and power relationships. Combination therapy is going to be needed, and until that happens, innovations like the ACA, although representing a modicum of real progress, really are like treating lymphoma or HIV with one drug. They'll make a difference for some, for a while, but will be undone by the underlying malady. Can we achieve justice and equity in just one sector of society, you might ask? because we can hardly expect all the actors in healthcare to unilaterally disarm and embrace an egalitarian, communitarian, ethical, non-commodified health sector when the rest of the society is far from that. But we shouldn't shy away from thinking boldly and broadly about what it will take to achieve justice for all in healthcare and society. In addition to changes in clinical practice, medical education, and medical science discussed earlier, we also need meaningful transformation in several other areas. It's imperative that we act both in our professional capacities and as citizens to promote these changes. As Don Berwick wrote in JAMA just recently, silence is assent. And academicians also, as we consider potential approaches, can play an important role in evaluating potential solutions. Some things will involve government action, provides the same insurance coverage to everyone. That would be single payer. Separate is never going to be equal. Approval of new treatments should be contingent on ensuring that they're available to everyone and should only occur after careful assessment of their marginal benefit and cost to society. The national academies should convene a panel to propose a substantially revised set of budget priorities for the NIH that gives far more emphasis to population health. And if clinicians are to continue to be paid on a fee-for-service basis, the Medicare fee schedule needs to be radically revised. In terms of communication, limit health system advertising to promotion of public health. Stop overselling the implications of biomedical science. Stop selling patients procedures they don't need. Provide greater transparency about all medical prices, including about what doctors earn when they perform a procedure on you. Establish media standards for much more balanced reporting on the implications of new research. As for patients and the public, provide them the social services and financial and psychological resources needed to address problems best dealt with in those ways rather than through their usual sources of medical care. Educate patients and the public about the common good and the fair distribution of limited medical resources. Offer much clearer communication about the limits of what medicine can accomplish. Train clinicians who can relate to diverse communities, and incorporate communities into all levels of decision-making in research, education, and patient care. What will it take to change the trajectory of U.S. healthcare and achieve justice for all? Change consciousness, in corporations, practitioners, and consumers, all of whom see it as a bundle of goods rather than as a potential societal resource. Make it a priority to transform discourse about healthcare and relationships within healthcare. Pursue consensus that we're all in the same boat, and don't give up with each inevitable failed effort at reform. Rabbi Tarfon, 2 millennia ago, said something that's still true. It's not your duty to finish the work, but neither are you at liberty to neglect it. Thank you. I would welcome comments, criticisms, attacks, or affirmations if there are any.
Okay, I'll try to speak loudly. So people feel free to approach the microphone or ask questions from your seats. But the one that I'll start out with is, as we grow, work in the area of health services research and train a new generation of scientists in that area, I know there's many possibilities, but what do you think some of the key questions that are going unanswered or we have not explored deeply enough?
Well, I have this intimidating array of things that we can work on, right? How about taking on some of the big ones or some combinations of these and thinking about, it's complex, thinking about the kinds of designs that would be necessary to evaluate effective programs. I don't say how it is we are going to select medical students more effectively who would be more committed to these kinds of priorities and have these kinds of values and competencies. But studies that could figure that out would be highly desirable. Figuring out how to communicate with the public better about healthcare and limitations on healthcare. Trying in a society where the perspective on the common good has been lost, as so many have said, to reactivate that. It was actually in one of the Federalist Papers that one of them talked about this as a central tenet of what they were trying to accomplish in the US, but that seems to have been lost. So there's some big things to think about, and some of it may not look like this is the study of healthcare, but I think that all of these things are relevant to moving healthcare towards what it could be. I mean, I remember when I began my fellowship in the late 70s, people were worried that the 6 or 7% of GDP going for healthcare was going to accelerate to 10 or 12. Well, we can continue to expand what we're doing and go to 25 or 30, but there's an enormous price to be paid in terms of what society is able to do in so many respects. So thinking about how we're going to make these kinds of systemic changes in healthcare, sure, would be a good place to start. And who's going to fund that kind of research? Well, I don't have the answer to that, but I think that we shouldn't just be happy when we get a slight increase in the NIH budget or when whatever increase goes to moonshots. I mean, if there's going to be moonshots, the moonshots should aim at saving the planet, as it were, in terms of healthcare.
Sean Granis. Sean Granis. I am trained as a family physician, and my wife is a practicing family physician, and I violently agree with the symptoms that you're describing of the problems of our healthcare system. I wonder, if part of the problem, and I'm curious to hear your perspective on this, is, and I think you've said something about this, but we're fundamentally, our culture is a market-driven, capitalistic, and a lot of these symptoms are due to that culture. And it strikes me that if we're going to get at some of these issues, we actually have to, sometimes in jiu-jitsu they say use your opponent's momentum against them. Are there market-driven strategies that could be used to overcome some of these? And I've heard of two. One is get rid of the third-party payer system. The patients wanting their share of the goods, they don't pay for it, so they can feel comfortable asking for it. So are there ways of changing behaviors through market-driven mechanisms? The fact that the U.S. residency system is entirely funded by the government and limited and constrained today, I've heard some people say, let's expand that. Let's make it a market-driven residency system to enable more, more value for, some people argue that the lack of primary care providers is due to the fact that we have a constrained residency training system today. So I'm curious, I've thrown a lot at you, but I'm just curious to hear your thoughts.
Well, first of all, I would say that providing everyone with medical care is the most important thing that can be done. Providing them with equivalent medical care clearly would be necessary. I don't think Medicaid is a solution. None of us would go looking for Medicaid coverage in preference to our employer-based. In terms of market approaches, lots of health economists are trying to do these little market manipulations, and the ACA was full of those kinds of things that were intended to fix problems. And, they may have moved things a few millimeters here or there, but they all fundamentally didn't solve the problems. I think just as, when we talked about the market, healthcare as a market commodity. One of the problems is that in any market, there are going to be winners and losers. Now, the U.S., things are worse than they are in other countries. I mean, I don't think Germans and French and Canadians and Brits are less capitalistically inclined than Americans, but somehow we've managed to find the worst set of things that we can do. I actually believe that we need to transform society, as you could probably figure that out from what I was saying in my talk, right? Very substantially. But short of that, there's lots of things that we could do to mitigate some of these effects. Certainly not paying people more for you know, a 12-minute visit to an ENT doc than a generalist earns in a month would be a starting point for not spending a lot of money on things we don't need and putting resources into things that we do need. Some of the problems are way outside of what we can do, providing financial resources and social services broadly to society, helping to address the epidemic of loneliness, which affects the use of medical care in society. I mean, these are very broad societal problems, but we can be advocates for things that need to happen in society. Rudolf Virchow, the German pathologist and physician, was a social activist. He said health, medicine should be a social science. And he advocated for more justice in healthcare, but he also joined the barricades in the Friedrichstrasse in the failed revolution of 1848. So there's lots to do and lots of ways in which we can act. And it's not necessary, we're not going to get there necessarily in any of our lifetimes, even those of you who are young, who can't imagine that your lifetimes will ever end. It's a dirty little secret that life is short. So, but you'll discover that soon enough. But we should take on these problems. And as Tarfon said, you may not finish it, but you got to start it, and you got to start somewhere. And we shouldn't just be self-satisfied when we get a grant or when we get tenure or whatever, right? We need to feel like there is so much more that we need to do. You know, as when I gave the anecdote about my uncle and one's value, and I asked myself, and I confirmed this when I talked to other relatives, what would he say now if he were alive about my worth? And he would say the matter is not yet settled because there's still more that you can do.
Okay. Hi, I'm Monica. I work up in CBMI, and my question is about thinking about bringing these social changes and social consciousness changes that you're talking about, because in the field of, well, okay, so when I was looking into public health as a future career, someone told me along the way that if I wanted to practice public health, I should get an MPH, and if I wanted to do research, I needed to get a PhD. And like, not everyone who wants to make a difference in public health wants to go through the process of getting a PhD. And also the idea that having a doctorate is necessary to conduct research can get in the way of people with other terminal degrees participating, like with MFAs, I mean, people with MPHs who have a great deal of practical knowledge. So I'm just curious what your attitude is about widening the field of people who can participate in the kinds of research we do at places like this.
Well, you certainly don't need to have a PhD to participate in research. But, you know, research does have to get funded, and often the funding goes to people who have doctorates of different sorts. But yes, I mean, I strongly agree that when you look at the kinds of problems that need to be addressed, there are many kinds of expertise and experience that can inform the design of studies, the content of studies, and the evaluation of programs that one might consider. Absolutely.
I'll end the questioning here, but Dr. Shapiro, thank you very much for joining us and providing a comprehensive diagnosis of the problem and challenging us all in our individual roles to identify solutions. So thank you very much, and feel free to stay if you'd like to discuss more.